So if you take a picture of this slide, you don't have to take any notes because you can find everything I've been collecting over the last 4 months. I have no conflicts related to this presentation. So when I was asked by Anga if I was willing to give an overview of the hot topics in infectious diseases from 2020 and 2021, I was kind of reluctant, but then I also thought it would be an excellent way to catch up with the delay of the literature over the last 2 years, because I had been busy with COVID full-time for 2 years. So I accepted the challenge, and then I started asking my colleagues, please help, mail me your top papers. And then I also reviewed the table of content of these journals, which took some time, I can tell, because I had to skip COVID, which was a challenge. And I tried to skip this very interesting case report that I found. And then in the end, I made a 100% subjective selection. And you probably ask, how is it possible to catch up with such an amount of literature? Well, I take the train to Rotterdam from Antwerp 6 times a week. So that's 8 hours approximately that I can use for that. And it's really relaxed. Well, not always. But after 20 years, I know where I have to position myself to get a seat. And then, as Anga also coincidentally mentioned, I like endurance sports, so I do a lot of very long endurance training in-house on my bike. So then I can review a lot of papers all the time. So that's how I try to do it. And these are the 4 topics I will discuss. And let's start with monoclonal antibodies. And before 2020, they were actually providing us work, these monoclonal antibodies, like rituximab or alemtuzumab. But then things are starting to change. Already in 2019, for the first time, a treatment seemed to lower mortality for Ebola, and these were 2 monoclonal antibodies. And recent publications also showed that with 1 injection preceding the season of RSV, you can protect high-risk neonates with a monoclonal antibody. And during the COVID years, I learned a lot about monoclonals. Not only I learned to pronounce like casirivimab, imdevimab, sotrovimab, etc. But I also learned that the potency can be really extremely high, so you only would need 300 milligram to have a therapeutic level for 6 or even 12 months. And that has to do with the FC chain that you can modulate to increase the half-life. And this is a study that I want to discuss briefly. It's about prevention of malaria with monoclonal antibodies. It's an impressive first phase 1 study where the monoclonal antibody was actually isolated from a healthy volunteer that was vaccinated against malaria, and then one of the antibodies this person produced was extremely potent. It was targeting the very conserved protein on the surface of the parasite. And in this experiment, you look for healthy volunteers, and they get mosquito bites, so they get malaria. And if it works well, like 90% hit rate. And in this study, which was done during COVID time, so it was challenging, they gave the monoclonal antibodies in several doses, and then COVID came, so the experiment was discontinued, and a year later, almost a year later, these volunteers underwent the same exposure and the same injection. But the interesting part is that 2 of them who received the highest dose, and they anticipated that it would still be therapeutic 36 weeks after this single injection, they did not receive a second injection. And also in these two, they were protected. So the protection was really prolonged. So it's a first proof of concept study. Actually, there was very recently another study from the same group with an even higher potency monoclonal antibody. So it's an interesting concept. Of course, you will think this is not a solution for the countries where the problem is, but maybe, yeah, it may be part of the solution. And I think we will be using this in the future for travelers. So enough about monoclonals. They're here to stay. And I wanted to, of course, focus on Staph aureus bacteremia as well, because that's the bread and butter of the ID physician, as somebody on Twitter stated, and I found that that's a good statement. So, but when do we consider Staph aureus bacteremia as complicated? Laura, when would you call a Staph aureus bacteremia complicated? It's not a trick question. No, just focusing on the prolonged bacteremia, yes. What is prolonged? Okay, now we're talking. These two studies actually are really looking into this. When is a Staph aureus bacteremia complicated? It's a large prospective cohort study, and they included patients with a Staph aureus bacteremia. They excluded patients that had been bacteremic for more than 3 days without treatment. So yeah, I hope that will not happen a lot, but keep this in mind. These were excluded. And then they looked at the 90-day mortality in relation to the duration of bacteremia. And day one, if you have 1 day of bacteremia in this study, it means that you had a positive blood culture on the day that the antibiotics were started. So 2 days of bacteremia was positive blood culture on the second day of your antibiotic treatment against Staph aureus. Mortality, as we all know, almost 30%, and it really increased already from day 2 on. And actually, day 2 of bacteremia was the cutoff with the highest hazard ratio. So already, if you have a second day of bacteremia after you start your antibiotics, you can call it complicated. And if you look at the incidence of metastatic infections, it's also, as of day 2, you're at increased risk. So it confirms that indeed it's the bread and butter of ID physicians. And it also suggests that if you could shorten the bacteremia, you may improve outcomes. So that should be the top priority if we're treating these patients. And shortening the bacteremia, the complicated way, but the way we have to go as well, is to ask the surgeon and the intervention radiologist to drain the site of infection, and then maybe simpler would be just to add a second drug. But simple is, yeah, sometimes too simple. I think before I go to the combination therapies, and if that may work, just a brief notice. Probably also in Belgium, you have this discussion, do we have to treat with flucloxacillin, or can we give cefazolin or another cephalosporin? And we sometimes use cefalozolin. This is a nice retrospective study, and hopefully it will be confirmed in a study that as I understand it, is almost complete in France, so a prospective randomized study. But in this retrospective study on MSSA in endocarditis, they found a much lower incidence of side effects if you use cefazolin instead of cloxacillin here. Actually, at ID Week a few weeks ago, there was a randomized clinical trial comparing a new cephalosporin, or relatively new, with daptomycin. And there as well, it was a large study. They did not see any difference in effectivity. But now, moving to, I think, the more important thing is, how can we improve outcome by using different drugs or combining drugs? And probably you will agree, or maybe not, that daptomycin is rapidly bactericidal, so it should be the excellent compound to combine treatment with. So in this study, with MSSA, Staph aureus bacteremia. They added 5 days of daptomycin to the cephalosporin or the oxacillin. It's not a definitive trial. It's not a phase 3 trial, but they were looking at duration of bacteremia. And actually, the 2 days is for the combination. It's not for the monotherapy. So there was no signal whatsoever that the combination was better. But that's a small trial. Here, they did another combination. This is a large trial on MRSA bacteremia, and there have been in vitro data and also animal data suggesting that if you add a beta-lactam to vancomycin or daptomycin when you treat MRSA, that this may improve the outcome, shorten duration of bacteremia, despite the fact that you're treating MRSA. There are several mechanisms that may underlie this. And here they tested this in a large randomized clinical trial. It's really large because it's MRSA bacteremia. You'll see they included more than 300 patients. The primary endpoint was a composite of bad things, but it was a composite, and take that into account. And secondary endpoints were mortality and kidney injury. The bad news is that after 350 patients being randomized, the DSMB recommended to stop the study, not for efficacy, but for safety reasons. So the primary endpoint was in the good direction, but not conclusive, but it was a composite of several things. And bacteremia was really shorter if you combined treatment. That was statistically significant, as you can see, but mortality was not, actually the other way around. And there was much more kidney injury if you added the beta-lactam to daptomycin or vancomycin. So my prudent conclusion would be that duration of bacteremia may not be the best surrogate endpoint for Staph aureus bacteremia trials. Another trial on MRSA bacteremia, here endocarditis. So also I think a large trial if you realize that it's MRSA endocarditis, not something we see every day. And the primary endpoint was treatment success 6 weeks after the end of treatment. And this again was a composite endpoint. The study I was not very happy about the design because they said we do a MITT, but in the end they excluded several patients that should be included in an MITT population. Anyway, 155 endocarditis cases with MRSA, so still a large trial. And what did I see? There was a trend towards a better overall treatment success. And the effect on bacteremia was really striking. So the relative risk of ongoing bacteremia on day 3 was 0.15, very significant. There was lower microbiological failure, lower complicated bacteremia, but actually these endpoints included also positivity at day 3, so they're not really different endpoints. But again, much more serious adverse events that led to treatment discontinuation. So not just an AE, but an AE for which the treatment was discontinued. And overall, mortality, not really different. So very, I think, frustrating for the researchers. This is just the same in one picture. So you seem to have a good effect on the composites of the primary endpoint, but then in the end, the mortality doesn't seem to matter. And for those who forgot, I had forgotten myself, but this study is already from 2018. I think the largest ever done on Staph aureus bacteremia, where rifampin was added to flucloxacillin or other beta-lactam drugs, and it didn't make any difference on mortality. So that was Staph aureus bacteremia. So I don't have any answer what we should do if you have an MRSA bacteremia and on day 3 blood culture are still positive. except for trying to convince the surgeon again that he has to intervene, or the radiologist. So moving to something completely different, that's patients living with HIV and anal cancer. Maybe not something the microbiologist in the room is seeing every day, and also myself, I'm not seeing it every day, but first some background. The natural history of anal cancer is not too well defined, but it starts with a precursor lesion that eventually progresses to invasive cancer. And the incidence is much higher, up to 100 times higher in men who have sex with men. And also if you're HIV positive, the risk is also higher, not only in men there, but also in women. But prevention is hindered by the incomplete understanding of the natural history of this disease. So it starts with a precursor lesion, and then gradually the squamous epithelium will be replaced by abnormal cells until you, if you're unlucky, have an invasive cancer. So the HSIL or AIN are some kind of synonymous. First, in this study, as a background to the study that I'll discuss later, they followed a cohort of HIV positive and HIV negative men who have sex with men for 3 years, just to look at the natural history of these precursor lesions. So they recruited 600 men, 1/3 were HIV positive, and already the first interesting observation is that at baseline, half of them, if they were HIV positive, half of them had precursor lesions, grade 2 or 3. And then looking at these patients every 6 months, so undergoing an anoscopy, they found a really high incidence of new lesions, but also many of these lesions just disappeared if you observed, if you didn't do anything. And they also found some markers of that were associated with a higher risk or incidence of clearance, and also higher incidence of having these precursor lesions. So it's just as a background. Now, the last slide about this study that also is, I think, relevant for the next one is that at baseline they found 2 cancers and then 3 during follow-up. But actually, if they looked carefully, 2 of the 3 cancers that were diagnosed during follow-up had very likely already been there at baseline, because one of the patients had a lump that was only biopsied 6 months later, but it was already there at baseline, and the second patient could not be really examined well because he had a severe proctitis. So there was 1 progression to cancer in this rather large cohort, so an incidence that is relatively low. But then the study I want to discuss, and that's actually from 2022, so it's the only one that I used from 2022. First, the primary endpoint. This was a randomized trial, a very large randomized trial, where half of the patients with precursor lesions were randomized to a control arm, and they were scoped, if I can call it that way, every 6 months. And of course, if there would be a cancer at any time, they would get treatment. So in this control group, 21 new cancers were diagnosed. And in the intervention arm, what happened in the intervention arm, that's this. So there were 25 sites all over the US, very well-trained physicians that could do all of this. So try to get rid of the precursor lesion, and if it doesn't work, you treat again and again. So very well organized, so that's not the real life in every center. But to show this, to get to this evidence level, what did I have to do? And that's why I want to discuss this, because there is really a huge implementation gap after this study. They screened more than 10,000 HIV-positive patients to see if they had a precursor lesion. And then first they found some anal cancers, so these were of course treated. And almost half of these 10,000 had a precursor lesion, so these patients could be randomized into the trial. And eventually they randomized 4,400 HIV-positive men or women or transgender persons with a precursor lesion, and they were randomized to a control arm every 6 months or an intervention arm. And this study was done because there had not been any convincing evidence that the intervention is really working and preventing cancer. So in the end, there was a 57% with a p-value of 0.03 reduction in anal cancer. So it really has potential, and we're trying to do this. But if you calculate with the numbers, it becomes some kind of, maybe problematic, because the number needed to scope would be around 1,000 to prevent one cancer. So what we really need is, we need to be able to select the at-risk population better, and that's really tricky. Maybe we can first do cytology, and if that's negative, you can wait. Or maybe HPV testing, but that hasn't been very successful because most of these people are HPV positive, or increase the age a little bit, or only treat the grade 3 precursors, because the grade 2, they often go away, or they will become a grade 3, and then in the end you can treat it. There are several things that we don't know yet, and there is one also study from the group of Amsterdam that I think is interesting as a concept. There they looked at methylation of certain genes in the biopsy to see if they can predict who will get cancer and who will not get anal cancer. It was, I think, a very interesting study because in the end they worked together with other centers, and they had 10 patients that had anal cancer, and preceding the anal cancer, they also had biopsies of precursor lesions. So they could really look at the methylation markers preceding the event being cancer. So this may be one of the solutions, but just to explain to you that just like in women, anal cancer is also HPV related, and we may be able to prevent part of the problem. And finally, what else? There was a lot, but some things I think I have time can discuss. First, maybe you already do, but I think not all of us do this. We should stop treating patients with community-acquired pneumonia for just 7 days or even 5 days. We can do better. This is again a randomized trial, not a huge trial, but large enough. I think 300 patients were randomized on day 3, and if you were not immunocompromised, for me that's a problem because all our patients are immunocompromised, but in many settings that's not the case. If you're not immunocompromised, the infection was not complicated, was not a Legionella or Mycoplasma, and the patient was stable, no fever, oxygen was okay. They were randomized to stop or continue and treat for 7 days. Long story short, to the right is in favor of the 3 days. So it's not worse. And a similar study, larger in children, 800 patients were randomized with a pneumonia. And when I looked at the criteria, you would consider these patients to have pneumonia, and they called the study the CAPIT study, which is nice because you have to cut your treatment at 3 days. Again, non-inferiority whatsoever. So I think we have to implement this if we're not already doing this. Then gram-negative bacteremia. We sometimes have the discussion, we have a patient with a cholangitis, and then ERCP has solved the problem, and then we stop 1 day after, and we stop immediately. If the drainage is okay, we just treat for 2 days. And then we say, yeah, but there's no evidence, but yeah, that's what we do. This study tried to look at what is possible in gram-negative bacteremia, and it was a really elegant study in Switzerland. Of course, you exclude very complicated infections or, again, severely immunocompromised. But the stable patients, on day 5 were randomized to 3 groups. One was you just give 7 days, the other 14 days, and then the third group, which as an ID physician I think is of course interesting. You use your CRP, that's what we have, to guide your treatment duration. And you could stop even before day 7 if the CRP had dropped by 75%. And at least the strategy worked regarding duration of antibiotic treatment, because the 7-day treatment group, the median was exactly 7, but also in the CRP-guided group, it was also exactly 7 days. And then the third group, with which everything was compared, was the 14-day fixed duration. These were not healthy pyelonephritis women, 78 years median, some ESBL as well, and as you can expect, urinary and abdominal. In the end, non-inferiority all over the place, and if any, the CRP-guided may be better, but the study was too small to really show this. So you can shorten your treatment as well for gram-negative bacteremia to 7 days, and sometimes even shorter if your CRP has gone from 200 to 30, and the patient is doing well on day 5, you can stop on day 5 as well. Finally, a last study, also really interesting. I'm not a TB expert, but I think for the first time, a very large trial has now shown that you can treat for 4 months instead of 6 months, but not in Europe, because rifapentin is not available in Europe. So that's a pity, but it's 2 months, yeah, it's 33% shorter, so I thought it was a study to mention. And last but not least, the single most important study you perhaps have forgotten about. So I have a question, not for Laura this time. Which intervention caused this dramatic increase, even more so in the red than in the blue group? We see, who can guess? Almost exact. Can you make it more specific? Yeah, okay, excellent. So this was another hint, the temperature on the Y. So it's CO2 and methane. And I think we have to really realize what we're doing. This is another graph showing the same. And I suggest you read this book. And don't worry, the 400 pages were not written by Greta herself. She did a great job by writing in between the paragraphs, but it's really excellently written by experts, top experts. And it's really impressive if you just read the first 30 pages, what is going on. And finally, the single most important thing you can do is read this book, and yeah, you can read what I suggest. Thank you.
Thanks a lot, Bart, and also thank you for introducing us to some other sessions later about climate change. Mm-hmm. So we almost finished. I think, the same question for you in general. What kind of research would you do now?
I hope that in 5 years from now, we will not have the next COP44, where nothing has changed, because it's really extremely urgent that we change things, and it's not on the individual level, but also on the country level, European and global level. So I hope that will be the major change in 5 years, but I doubt it will be.
Okay, thank you. We almost finished.